Hello, everyone, and thank you all for joining us today. It's a pleasure to welcome you to the MSK Case Presentation Series. My name is Aline Serfari, and I'm honored to co-host this session alongside Dr. Hilary Humans, who has been coordinating and moderating this series with me for 5 years now. Our guest speakers today are Doctors Marco Bianchi, Joseph Craig, and Dyan Flores. Together, they will present a series of interesting cases highlighting the most relevant imaging findings and providing a literature review to enrich the discussion. And at the end, we'll have a Q&A session. If you have questions at any point during the presentations, please write them in the chat box, and at the end, the speakers will answer them. Today's presentations will be recorded and available on demand on the OCAD website, which is ocadmsk.com. Okay, so it's my great pleasure to introduce our first speaker, Dr. Marco de Andrade Bianchi. He earned his medical degree and completed his residency and fellowship in MSK Radiology and Intervention at the University of São Paulo Medical School, and he continues to serve there today as an attending physician in the MSK Radiology Group with a special focus on MSK interventions, having been instrumental in training more than 80 fellows in the field so far. His international background includes a one-year research fellowship at Bates Frail Deaconess Medical Center, Harvard Medical School in Boston. Currently, Dr. Bianchi is the head of MSK Radiology Group at Rede D'Or, the largest hospital network in Brazil with over 100 facilities nationwide, where he also coordinates the MSK Fellowship Program. He has authored and co-authored numerous scientific articles and book chapters, and he's a frequent speaker at major national and international radiology congresses and maintains an active role within both the São Paulo Radiology Society and the Brazilian College of Radiology. Beyond his professional accolades, Dr. Bianchi is a dedicated water sports enthusiast. He holds an international sailor's captain's license and continues to train weekly with the USP Medical School water polo team. Please, Marco, take it away.
Thank you, Aline and Hilary, for the invitation and for the kind introduction. I'm glad to share with you an interesting case we had here at the university. I'll present a case, a very interesting and challenging case of an 8-year-old male patient with no known comorbidities, with 2-year history of pelvic and right hip pain associated with progressive gait impairment. And the symptoms were worsening over the past 2 years, more pronounced at night and with partial relief with common analgesics. On physical examination, he had a right-sided antalgic gait and hip mobilization and palpation. On the X-ray, we couldn't see much because of the gas interposition, but we slightly can see a right sacrum bone marrow alteration compared to the left side. Actually, he presented to the service with external examination, MRI. We can see the T1, the T2, and the post-contrast sequences. And the report of this external MRI was aneurysmal bone cyst. Actually, on the T2 and the P, the fluid sequences, we can see the fluid level with a lytic and expensive lesion with fluid level, which calls our attention for aneurysmal bone cyst. But on T1, on post-contrast, we can see also very intensive edematous reaction from the bone marrow and also from the soft tissue adjacent. On the coronal image, we can see mainly the cyst component of this lesion, but we can also see the edema from the bone marrow and soft tissue edema, and we can slightly see a nodular solid component as well. So the sequences, we can see mainly the cystic lesion, and in the axial images we can see the cystic with like a fluid level and heterogeneous nodular enhancement and nodular solid component as well. We repeated the MRI in our institution with a better resolution. We can see the cystic with fluid component, and also some nodular component as well. We performed an CT, which helped a lot to see the lytic component of the lesion with that in that part that we saw a nodular solid component in the MRI with calcifications, internal calcifications, and also the well circumscribed findings with a sclerotic reaction of the bone marrow adjacent, also and the cystic components. And we performed a biopsy guided for CT in 2 different sites, aiming for that solid and nodular components that we saw on the MRI, and with where it also we could see on the CT the calcifications, internal calcifications. So in the first site, the histological report, it was osteoblastoma, and the other site we sampled, it was fibrovascular myxoid edematous tissues, compared to aneurysmal bone cyst. So the conclusion of the report, the pathological report, was an osteoblastoma associated with aneurysmal bone cyst component. For summarize, we have a pediatric patient with pain and autophagic gait and worsen at night. At the MRI examination, we had a sacral lesion with fluid levels and marked perilesional soft tissue and bone marrow edema with post-contrast enhancement and perilesional sclerotic and well-defined, well-circumscribed lytic lesion. So the key images we have this typical aneurysmal bone cyst with fluid level and some parts of solid with post-contrast enhancement. So it's a case of osteoblastoma that it's a rare osteoblastic neoplasm, less than 1% of primary bone tumors. It's a benign bone tumor. Epidemiology, it's in young patients from 10 to less than 30 years with a slightly predominance in male. Clinical presentation is typical with insidious pain, worse at night, and partial response to aspirin. In the spine, it's predominantly posterior elements, especially in spine and cervical spine and sacrum. In the long bones, we have in metaphyseal regions. I have some cases to illustrate. On CT, it helps a lot to see the lytic lesion, expansive predominantly lytic lesion with peripheral reactive sclerosis. We can have needles or internal calcification and cortical thinning and remodeling, and sometimes even with rupture. At MRI, we have T1 heterogeneous with T2 hyperintense or ABC-like fluid levels, may show aggressive imaging features, including extraosseous extension and periosteal reaction. It's markedly for the bone marrow and soft tissue edema. Here a case. And the other component, it's a aneurysmal bone cyst. It's a osteoclastic neoplasm primary is most common, but in 30 can be secondary to another lesion, even up to 30%. Epidemiology, it's also in children and adolescents, just like osteoblastoma or osteomastoid. In patients older than 20, 30 years, we have to think about having a secondary lesion as well. Clinical presentation may be asymptomatic. It always, most of the part of the time, it's asymptomatic, but can be pain or complications related to pathologic fracture, for example. Typical locations in the long bones is more common in metaphysis, femur, and tibia, or in the spine. It can involve any segment. Predominantly in the posterior elements, but can be in the vertebral body as well. Here an example of the literature with a lytic expansive lesion with well circumscribed, showing a slow growing lesion. In the MRI, is typical with this thin septum with fluid levels. Can be thin gadolinium enhancement in the septum and in its walls. Secondary aneurysmal bone cysts can occur in osteoblastoma, chondroblastoma, fibrous dysplasia, giant cell tumor, non-ossified fibroma, and osteosarcoma. The clinical history, epidemiology, anatomic location, imaging features help us to differentiate from primary or secondary aneurysmal bone cysts. So the epidemiology is common in the both diagnosis, but the nocturnal pain and function limitation show us inflammatory lesion, just like the osteoblastoma. The posterior sacrum elements is classic for osteoblastoma, and the marked perilesional edema, sclerosis, internal mineralization, and nodular uptake compacity is very typical for osteoblastoma compared to aneurysmal bone cyst, and it helped in our case. This differential diagnosis, we have to think first and mainly to exclude the worst one, that would be telangiectasic osteosarcoma. To differentiate the telangiectasic osteosarcoma, it appears with a larger lesion with much more aggressive presentation, with more solid component and cortical rupture and mass, extraosseous mass, and much the solid component with post-contrastion enhancement, and can be elevated alkaline phosphatase. Following up our case, our 8-year patient case, we discussed this case in our multidisciplinary meeting. We have weekly on Fridays, and the surgery was an option considered, but for its morbidity, we suggested to perform radiofrequency ablation of the osteoblastoma. But on MRI, we were not confident to clearly delineate the nodular component of the osteoblastoma. So we performed a PET-CT, aiming to see where we have most FDG captations. So we performed a radiofrequency ablation guided for those areas on PET-CT. We did 2 sites radiofrequency ablation, and the patient did very well. One month after the procedure, he was much better with his symptoms. So it was a very challenging diagnosis and treatment as well. But the take-home message, as a take-home message, we would like to say that aneurysmal bone cyst is very typical and easy to define as a diagnosis, but we don't be satisfied with aneurysmal bone cysts. Look for findings that suggest a secondary lesion associated. Like the main features is clinical history of pain, symptoms, and worsening, age, especially after older patients older than 20 or 30 years. Imaging findings, atypical location, soft tissue component, thick enhancement, and marked perilesional edema. And osteoblastoma is easier to diagnose with a lytic lesion. Perilesional and bone marrow edema is like a big osteoid osteoma. And I would like just to illustrate a couple of more cases that we did perform radiofrequency ablation with inflammatory lesions as well. It's typical. The first one is a typical osteoid osteoma on the tibia with a very edema with the bone marrow and perilesional and cortical thickening. We perform a radiofrequency ablation, and this is a 6-month control with no edema, just the halo of osteonecrosis, and the patient was asymptomatic. The other case, the last case is 19-year-old patients that came with a partial resection of a chondroblastoma in the distal femur with persistent pain. So in these two images, in T1, T2, we can see the lesion, the tunnel of the surgery, and the lesion was still there. And we performed a radiofrequency ablation, and 1 year after the radiofrequency ablation, the edema was gone and the patient was asymptomatic with no other complications. These are the references. Thank you very much.
Very nice case. I'll have some questions later. Okay, now it's my pleasure to introduce Dr. Joseph Craig, who's worked on staff as a musculoskeletal radiologist at Henry Ford Hospital in Detroit for the past 32 years. He completed his MSK fellowship training at the University of Michigan Hospitals and did his radiology training in New Zealand, and is a fellow of the Royal Australian and New Zealand College of Radiologists. He's also American Board Certified in Radiology. Dr. Craig is Clinical Professor of Radiology at the Wayne State University School of Medicine in Detroit, Michigan, and is Program Director of Musculoskeletal Radiology Fellowship at Henry Ford Hospital. He enjoys all aspects of musculoskeletal radiology, but in particular MSK, MRI, and ultrasound. In addition to being brilliant and accomplished, he's also one of my best friends in the world, so I'm very happy that he's agreed to participate in this case series.
So thank you very much for those kind words, Hilary and Alina. Thank you for inviting me to talk today. So I'd like to present this interesting case. So a 43-year-old female patient presented with progressive lower extremity and back pain. The patient had bilateral midfoot pain initially, which progressed to encompass her ankles, knees, and hips over several months. And here, these initial radiographs of her feet, we see quite marked periarticular disuse type osteopenia around her tarsus bilaterally, tarsometatarsal joints, and her MTP joints. A nuclear medicine bone scan was ordered because of the joint pains. And on the initial images, we see there's some increased uptake in the right foot in the region of the first MTP joint. The nuclear medicine scan also showed diffusely increased uptake involving her ankles, knees, and hips bilaterally. Radiographs of her right and left knees, these are the AP views, and they show again that there's quite marked osteopenia of her bones with nothing particularly focal to see on the x-rays. Here's an MR of her right knee, and if we look at the proton density images, we see multiple insufficiency type fractures through the distal femur, the medial femoral condyle, and through the tibial plateau. Interestingly, on the FATSAT T2 coronal images, it's harder to see the fractures, and they don't produce much edema. Here's the patient's left knee, and it's virtually a mirror image of the right knee, with again multiple insufficiency type fractures through the distal femur, the femoral condyles, and the proximal tibia. And again, those fractures are harder to see on the coronal FATSAT T2 weighted images, and there's a little bit more edema around one or two of the fractures than we saw on the right knee. On the right and left hands, there was some periarticular osteopenia around the MCP joints, PIP and DIP joints. The striking feature, though, was the pseudo-fractures involving the distal phalanges. Also, the image on the right, cone down image of the index finger, we see that there's a more focal soft tissue swelling on the radial aspect of the distal phalanx of the index finger, which we'll talk about in a minute. Biochemistry was ordered, and the pertinent findings are that the alkaline phosphatase was elevated, PTH was elevated, the serum calcium was normal, both 25 hydroxy vitamin D and 125 hydroxy vitamin D were decreased. And probably the most important finding is that the serum phosphate was decreased. And this last finding is the red flag, like the smoking gun, as to the problems this patient has. Here's an MR we did of the patient's left foot, where we saw that area of increased uptake on the nuclear medicine scan, and we can see there's a focal mass on the undersurface of that first MTP joint. It's low density, low signal rather, on the coronal T1 image, and interestingly, it's quite dark on the sagittal FATSAT T2 image. After administration of gadolinium, it was quite focal uptake, quite marked uptake by the tumor. So the patient subsequently went to surgery, and 2 masses were removed. That area of soft tissue prominence in the right index finger, a piece of that was removed. A discrete mass wasn't found at surgery, just diffusely swollen tissue, but some of which was removed. And then that focal right that focal foot mass, which measured 4.5 centimeters maximally, was removed in its entirety. And also we sent it to the Mayo Clinic to Dr. Andrew Folpe, and it was stained for this protein FGF23. It's an immunoassay, and it was positive. And we'll talk about that in 1 minute. On the image on your right, from the right index finger, there's some spindle cells with nuclear variation and associated hemosiderin deposition. No focal tumor was found, and the findings were non-specific, but thought to relate primarily to the changes in the soft tissue from the metabolic abnormality. Here's 2 histologic images from the foot mass, and on the image on your left, there's a spindle cell population of cells with associated hemorrhage in the inferior third of the image. In the upper portion of the image, there are areas of tumor with hyalinized fibrosis. And on the right-hand side, there are also spindle cells with admixed osteoclast-like giant cells. And here's a graph in The markers below are month markers, and here's a graph of her serum phosphate, and we can see before surgery was significantly decreased, and then at the time of surgery, within 24 hours, it returns back to normal. It overshoots a little bit, but it's still within the normal range, and then it comes back over and remains normal. So osteomalacia is defective skeletal mineralization, and it's caused by any condition that causes inadequate calcium or phosphate mineralization of osteoid. And then this condition, tumor-induced osteomalacia, it's an acquired paraneoplastic syndrome. It's a rare cause of osteomalacia. The first case was reported by McCants in 1947. It's characterized by hypophosphatemia, hypophosphaturia, and inappropriate or sometimes inappropriate normal or low levels of 125 hydroxy vitamin D. Other features include ALK phos being elevated, decreased resorption of phosphorus in the renal tubules. Typically the calcium is normal, which we saw in this case, and normal to elevated PTH. Actually, in our case, the PTH was decreased. And interestingly, clinically and biochemically, it can mimic these two other conditions: X-linked hypophosphatemic rickets and autosomal dominant hereditary hypophosphatemic rickets. In this paraneoplastic syndrome, patients often present with symptoms of diffuse pain and tenderness, a waddling gait, and progressive functional disability, and that's what this patient pretty much had. And insufficiency fractures are very common. The histologic features, it's a rare tumor. It's a small, slow-growing mesenchymal in origin. And histologically, these tumors can be categorized into four categories. And Dr. Folpe from the Mayo Clinic has wrote the classic article on this in the American Journal of Surgical Pathology in 2000. But he described four types. So the mixed connective tissue type, which is the most common. And then some of the tumors are osteoblastoma-like tumors, some are non-ossifying fibroma-like tumors, and some are ossifying fibroma-like tumors. And in the past, we used to think that the soft tissue, the PMT ones have been called various names, including when I was a resident, we called them hemangiopericytomas, and we knew these tumors could induce intense osteomalacia, but nobody really understood the mechanism. It was also thought that osteoblastoma occasioning non-ossifying fibroma and ossifying fibroma could do this. In actual fact, it's all these are the one tumor, and what these tumors can do is mimic an osteoblastoma or a non-ossifying fibroma, and occasionally ossifying fibroma and even chondroid tumors they can mimic. The most common histology is this PMT, phosphateric mesenchymal tumor mixed connective variant. And they're characterized by a mixture of spindle cells, osteoclast-like cells, microcyst, prominent blood vessels, cartilage-like matrix, and neoplastic bone. And I've taken this from the literature, nice article from Dr. De Boer and colleagues in JAMA from 2005. I just point out that when you have low serum phosphate, it activates the final step in conversion of vitamin D to its active form, 125 dihydroxy vitamin D. And then when you have low serum phosphate in the proximal tubule, there's an increased activity of the apical sodium phosphate co-transporters reabsorbing phosphate back into the body through the tubule. So that's normal. Now, FGF23 is a protein. It's got about 250 amino acids. Since it's made and secreted by osteocytes and osteoblasts in response to 125 hydroxy vitamin D, it's shown to decrease the activity of the sodium phosphate co-transporters in the proximal tubules, and that causes inhibition of sodium phosphate resorption, and so enhancing phosphate excretion in the urine and decreasing serum phosphate. It also inhibits the conversion of vitamin D to its most active form, 125 hydroxy vitamin D. So interestingly, this FGF23 protein is also involved in the heritable causes of hypophosphatemia. In autosomal dominant hypophosphatemic rickets, there's a mutation in the FGF23 gene, and the mutation prevents degradation of FGF23. In X-linked hypophosphatemic rickets, there's a mutation in the so-called PHEX gene, or PHEX gene, which encodes for an endopeptide that would degrade and deactivate FGF23. And here's another nice diagram from Dr. De Boer's article in JAMA. And so normally FGF23 is regulated through cleavage, enzymatic cleavage. In tumor-induced osteomalacia, there's overproduction. In autosomal dominant hypophosphatemic rickets, there's a mutation in the FGF23 gene, and it's resistant to enzymatic cleavage. And then in X-linked hypophosphatemic rickets, there's a mutation in the PHEX gene, and so there's impaired enzymatic cleavage. So in summary, I present a case of osteogenic osteomalacia. Patients frequently present with diffuse pain and weakness. They usually have multiple insufficiency type fractures. And we have quite a big primary bone and soft tissue tumor service here. It's not a common tumor, but I've seen a number of them over the years. And typically they present in this way. They have hypophosphatemia, hypophosphaturia, and inappropriate and levels of 125 vitamin D. Now, one point I'd make is, like, normally in the US, serum phosphate is not measured routinely. So if you're thinking of this condition, you need to ask when the biochemistry screen to include phosphate. And then other features include elevated ALP phos, which this patient had, decreased resorption of phosphorus, normal calcium, which she had, and normal to elevated parathormone, which actually she had low parathormone. And typically biochemistry returns to normal within 24 hours after resection of the tumor. Most of the tumors are benign. Occasionally you can have a malignant one. Well, I've seen one malignant one in my career here, but most are benign. And another thing I would add is sometimes it takes months and months and months and months before the diagnosis is made. So thank you very much.
Thank you, Joseph. Now it's my great pleasure to introduce you to Dr. Dyan Flores. She completed her radiology training at Makati Medical Center in the Philippines, followed by fellowships in the US, Philippines, and Vancouver, Canada. She's an assistant professor at the University of Ottawa and works as an MSK radiologist in the Ottawa Hospital. Her clinical and academic interests include image-guided pain and oncologic interventions and sports imaging, particularly muscle, hand, and wrist injuries. Dr. Flores is an active member of the Radiologic Society of North America, International Skeletal Society, and Society of Skeletal Radiology, and is a two-time recipient of the RSNA Honored Educator Award. And she's also a dear friend of mine.
All right, so good afternoon, everyone. Thank you to Hillary and Aline for the kind invitation. I'm happy to be back. So we're going to look at a few wrist and hand cases today. So I'm going to scroll through the images. So this is the first. This is a 59-year-old woman, fell on an outstretched hand with persistent pain 1 year after. So the radial side is on your left, and we are scrolling proximal to distal. Okay, so the key findings here are a distal radius fracture, and you have here this fluid-filled area in blue arrows over the ulnar aspect of Lister's tubercle, which is indicated by the asterisk. So this is where extensor compartment 3 or the extensor pollicis longus tendon is supposed to be. So in this case, that's empty, so that's consistent with a tendon tear. So this was confirmed on coronal MRI, which showed this large tendon gap along the dorsal and radial aspect of the wrist. So this confirms your tendon tear. The distal radius fracture was also shown on the previous radiograph, and here we have the undisplaced fracture. So this was a case of extensor pollicis longus tendon tear and fracture of the distal radius. So when we think of pathologies of the extensor compartments of the wrist, you can usually characterize them based on the specific compartment. So for compartment 1, you have your Decker veins, tenosynovitis. For 2 and 3, you have your intersection syndromes. 4 and 5 are not too exciting. There's really not a lot of things going on in there. And extensor carpi ulnaris, or ECU, compartment 6, where mostly you just have tendinitis. So I like to think of the wrist like a busy train station with tight compartments and narrow tunnels. And so many tendons from the forearm pass through these tight spaces at the wrist to move your fingers and hands. So every time you write, you lift, you grip, those tendons glide back and forth through those tunnels. So you have high repetition, you have tight spaces, you get more repetitive trauma rather than acute. On the other hand, acute EPL or extensor pollicis longus rupture in association with a distal radius fracture, these have been reported in literature. They're actually more common with non-displaced fractures, like in our case. The incidence is about 5% in non-displaced fractures and 0.3% overall. Several mechanisms have been proposed, like local adhesion, ischemic injury due to damage to the blood vessels in the area, tendon laceration. The tendon is also very prone to compartment narrowing if you have swelling and hematoma. So the tendon is prone to rupture at the tubercle because it sharply changes direction around this prominence. So that creates high friction and contact stress. The segment of the tendon also has relatively poor blood supply, making it more vulnerable to ischemia and impaired healing after minor injury. So following a distal radius fracture, you can have swelling and hematoma within that tight third extensor compartment, which can further compromise your tendon attrition and gliding. Fracture fragments and callus may also mechanically abrade the tendon at this location, causing attritional wear. So as a result, delayed rupture classically occurs weeks after a distal radius fracture. So for reference, when you look at a normal MRI, so because of the sharp turn at Lister's tubercle, the tendon is also prone to magic angle artifacts. So here you have a very low signal tendon, very normal, and then you go distally and it changes into this artifactual intermediate or even bright signal. And you will be surprised how long that segment of the tendon is with that artifactual bright signal. Sometimes I'm already at the level of the thumb before that low signal comes back. So the shape of the tubercle might also influence the risk for a tendon tear. So these are the 6 subtypes reported in a study from 2025, which found that for non-displaced distal radius fractures, the tendon ruptures more often when the tubercle has a type 1B shape, wherein the radial peak is higher than the ulnar peak. So this altered bony contour may increase friction, compression, or mechanical irritation of the tendon, particularly during thumb motion, which makes sense because that's where your thumb is in the radial side of your hand, making it more vulnerable after a fracture. So these are a few companion cases. So this was a patient who came to us from the community just for nonspecific dorsal-sided wrist pain after trauma. And it was positive for an EPL tear. So the calipers here show the tendon gap. So you might be thinking, why did they go straight to ultrasound? So the patient could not move his thumb, and they did obtain radiographs first, but only of the thumb, which makes sense given the clinical presentation. So here are the images. They already put a cast in it. It was normal. So in our practice, I think out of 10 patients who come to us in ultrasound for concern for an EPL tear, probably 7 will have a distal radius fracture. So for this case, we recommended a dedicated wrist radiograph, which confirmed the non-displaced distal radius fracture. So specifically in our hospital, we have discussed this with our hand surgeons. So what they do is that they just do a 2-in-1, and they recommend radiographs of the entire hand, which covers both the thumb and the distal radius. And again, here in this case, you have a positive EPL tear and a distal radius fracture. Again, non-displaced, very subtle, as shown here on the radiograph. So this is another related case. Distal radius fracture right here. And on lateral view, you have this maybe small fragment protruding a little bit in the dorsal aspect. So this patient had difficulty extending his thumb. So usually we also do dynamic flexion and extension of the IP joint with a transducer and short axis over the tubercle. So this is the image. A portion of the tubercle is displaced, as shown in blue, and you can kind of see the tendon going inside, indicated here by the yellow arrow. So we couldn't find a tendon gap here. However, we did a cine image in long axis. So that's the fragment. And here are some of your deeper fibers of your tendon. And you can clearly see, you can imagine how much that tendon is being abraded by the fragment. The portion of the tendon right here was a little bit thinner, maybe a little attenuated, but overall there was no gap. And this patient was managed conservatively, but with persistent limited thumb flexion and extension. So this is the second case. This is the 60-year-old man slipped on ice last winter. So again, we're scrolling proximal to distal. Okay, so this was a little bit more straightforward. So this was a flexor pollicis longus tendon tear. So here are key images showing the distally retracted tendon stump. So that's very easy to diagnose. It's in the middle of a fleshy muscle, indicated here by the blue arrows, but the proximal stump was actually located near the level of the carpal tunnel in yellow arrows. So flexor tendons, in contrast to your extensor tendons, pass through a narrow carpal tunnel. They are usually deeper and are surrounded by more muscle bellies. Tears in general are more commonly seen in the hand and usually occur by laceration. So this is an easy diagnosis since flexor and extensor tendons in the digits are superficially located and are readily depicted on both ultrasound and MRI. However, this case today was a flexor tendon tear that occurred at the wrist. So in general, flexor tendon tears in the carpal tunnel are less common than those in the hand and are less commonly due to trauma because of the anatomy. So the carpal tunnel is naturally designed to protect the tendons. It is a protected zone. These kinds of tears can occur in atraumatic conditions. The most common, of course, is rheumatoid arthritis. Now, flexor tendon tears at the carpal tunnel are particularly difficult to evaluate in ultrasound because of their depth. So when assessing extensor tendons on ultrasound, evaluation is relatively straightforward. You can simply move around the wrist while identifying the extensor compartments, counting from 1 through 6. In contrast, the flexor tendons within the carpal tunnel are deep, and they're kind of smushed in this sack of structures, so kind of like a sack of marbles. In practice, few people actually count the individual tendons at this level. I don't know of anyone who does it. As in our case, the main clue to a flexor tendon tear is the retraction away from the carpal tunnel rather than direct visualization at the level of the carpal tunnel itself, like our pathology. So this is the companion case, a 46-year-old man with pop in the palm after lifting. So again, going proximal to distal. Okay, so this one might be a blink and you'll miss it kind of case. And we were able to make the diagnosis here by a lot of scrolling back and forth and the clinical history, which specified the fifth digit. So as we scroll proximal to distal, there was some fluid signal here, which you can easily disregard as maybe just a vessel. However, that was kind of persistent. Now, as these tendons start to go to their respective digits, you can kind of see a shadow of a tendon here, maybe here, definitely missing here, definitely not as robust and dark in signal as the other tendons. The tendon of this digit is smaller, but it's not supposed to be absent. And we see here some tissue finally attaching to the digit. So this case was tears of your fifth digit flexor tendons. The stump was actually located in the carpal tunnel itself, best demonstrated on the coronal image. So in our institution, almost everyone requests for an ultrasound first for hand and forearm tendon tears. Very easy to just extend your field of view. You don't need additional acquisition time. But in general, while I think it's sufficient for extensor compartment injuries, for flexor tendon injuries, I usually prefer MRI just because this area, like I said, is quite deep, hard to access in sonography, and though rare, tears at the carpal tunnel can occur and may be missed. So in summary, I presented two cases of tendon injuries at the wrist, which I think are not as commonly discussed as those in the hand. So EPL injuries are classically associated with distal radius fractures and often present in a delayed fashion. So patients may complain only of thumb weakness or inability to flex and extend, while prior wrist pain has already resolved. Finally, tears of the flexor tendons at the wrist may be harder to evaluate than the extensor tendons. So they are in a deeper, naturally protected position, which makes injuries more difficult to depict on ultrasound. So if clinical suspicion remains high, despite equivocal initial imaging, MRI should be considered for further evaluation. So thank you very much.
That was beautiful. I have a couple of questions for you since you just
Yes.
taught us about the wrist and hand tendon tears. I was not aware of the seemingly strong association between distal radial fracture and EPL tendon tear. You mentioned that it's not acutely torn at the time of injury. It's a delayed complication. How long is that?
So usually after a couple of weeks. So it's so common in our practice that I use it now to diagnose the distal radius fracture that was missed.
Right.
So
Right.
but it's usually delayed by maybe a couple of weeks. I learned it first in fellowship. It's quite common. So
I'm
in
clearly
Canada,
late
we
to the
do.
game here.
No. What I mean is like no, because I learned it from like when I was training in Canada, just because we do ultrasound first. So we always notice that like why does this keep getting torn? And then there's actually literature on it, and we were surprised that it's more common with non-displaced. So it's very rare that I usually see it in displaced fractures. But yes, so I use it now as a secondary clue that there was a missed fracture, just
Okay,
because of how.
in the chance that I didn't get the memo about something else, are there other wrist extensor tendon
No.
tears that are associated as a delayed complication with fracture?
So far for the distal radius fracture, it's just the EPL. That's it. That's what I look for. I'm like hypersensitive to it now.
Oh, that's so great. Really great. Thank you. Any other questions for Dyan while she's talking? Chat.
No, there's no question in the chat.
Okay. Now I have a question for Joe. Um, I over the years I've seen people whose bones were crumbling, but I didn't make this diagnosis. Um, now when I see multiple insufficiency type fractures, I'm going to think about it. But it seems to me that your patient presented with foremost foot pain. Is
Yeah,
that right?
yeah, they
So,
did.
I mean, that's the reason you targeted that nuclear scan on the feet, because when she had the total body scan, that uptake at her first
Yeah,
MT was hard to see,
yeah,
right?
well, I think it had gone, Hillary, because like they were delayed images for bone, right?
Right.
And like
Oh, 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 oh.
so I think you only saw it in the initial the blood pool and a little bit later, but it didn't hang around.
I
Yeah,
mean, I guess your point that you made was that the metabolic profile, including the serum phosphate, was so suggestive of the diagnosis that you were actively looking for a benign tumor. But
yeah. Well,
they can be really small. So like, how do you
so
find them?
so I think first of all, like that low serum phosphate is like a red flag, right? I mean, in theory, it could be one of those two other inherited conditions we talked about, but you have to exclude if you have those insufficiency fractures and a low phosphate. I mean, I think it's just about invariable that it's going to be tumor-induced
Right, but then you have to
osteolysis.
find
So,
it and chop it out. So the
so
best way to find
sometimes the patient knows where the lump is. This lady didn't tell us that she had a lump in her foot, but sometimes the tumors are very small and they can be difficult to find. In the olden days, that we'd do the octreotide scans, but they've pretty much gone by the by. So now, if you suspect you've got you're dealing with a phosphateric mesenchymal tumor, you don't know where it is, you should do a PET scan. And then there's even a subgroup of patients that they can't find it on a PET scan. So sometimes they can be very small, but it's like all the ones I've seen, except for the malignant one we had, when they resected the phosphate, actually, I think in the malignant one, the phosphate came back to normal too, but then the patient developed metastases and it went back up. But like when you resect the tumor, the biochemistry reverses, within 24 hours.
it. Okay. Okay. Now, Marco, I have a couple of questions. I missed, how long did that child have symptoms?
2 years.
Two
Two
years,
years.
right? Because so we wouldn't be thinking about an underlying malignant lesion because it was so chronic clinically, but also I noticed that there was atrophy in the ipsilateral paraspinal muscles. I had a very similar case millions of years ago where a child had painful scoliosis for many years, and it was a misdiagnosis, which was hard to believe. And as soon as the tumor was excised, the scoliosis was gone. It was really just splinting. But I have a question, and I don't know if you know it or maybe anybody in the group can unmute themselves and say it. I was taught that the literature talks about the percentage of aneurysmal bone cysts that are primary or secondary. But there was a famous bone tumor pathologist that I worked with for many years, Howard Dorfman, and he used to say that that's kind of nonsense that really 100% of them are secondary, but aneurysmal bone cyst is so aggressive that it obscures the features of a primary lesion, both on imaging and histologically. Does anybody have an opinion about that? Is that true? Not true?
The
Joe?
number I got in the literature, but I think I believe in that hypothesis. Maybe much more
Yeah, I
second.
mean, I was also taught, for instance, that when it's at the end of bone, even if you can't see the underlying lesion, you just, based on the age of the patient an aneurysmal bone cyst at the end of bone should be secondary to a chondroblastoma or a giant cell tumor, just based on location, whether or not you can see that.
Yeah, that's what I've heard as well. But most of the time, you can't find them.
Right. So it's just really it's just
So it's kind of difficult to prove or disprove, I guess. Certainly
Right.
difficult to prove.
Right. Yeah. I also thought that traditionally, I thought that the degree of edema with the osteoblastoma was less than the osteoid osteoma, and you may not have that nocturnal, pain pattern, but I don't know.
I don't know. My experience is that are very similar.
Oh, really?
I don't know how to say if it's more or less than one from another.
Yeah. Any other questions?
I'd like to make a comment on the Joseph case. As an enthusiastic of intervention radiology, I'd like to advocate the treatment of this phosphaturic mesenchymal tumor, especially intraosseous lesion, with radiofrequency ablation. We have a few cases here in the university with the partial resection lesions with the continuous symptoms and laboratorial findings. And when we performed the radiofrequency ablation, we treated and cured the patient. The days after the treatment, the levels of the blood samples normalize quickly, and it's much less morbid than the surgery. The orthopedic surgeon says that they keep digging the medulla and don't see, can't see if the lesion was completely resected. And we can see in the MRI or PET-CT, and we can target with CT guided and treat very, very successfully.
I mean, it's certainly true. Like if you don't get all the tumor out or you leave little bits of it, either the biochemistry never returns to normal or it does return to normal, but then it comes back abnormal. But did you have a case where it was actually in the bone itself?
Yes, 2 or 3 cases in bone.
I've never seen a case in bone. The only cases I've seen are within the soft tissues. And I've seen 2 or 3 cases where the primary was in the foot for some reason. I don't know why that is, but
maybe we can bring another time.
I mean, the thing that they might be against ablating it initially is that, like what if it was, they like to have histology. I guess you'd biopsy it because there's a small percentage of them that are actually malignant. Yeah.
Not in this case, in your case, because it was a small, very superficial and soft tissue lesion, but especially intraosseous lesions, the radiofrequency goes very well.
Okay, thanks.
Dyan, you mentioned that APL tears are relatively common in your practice. Do you think there is a specific reason for or patient population contributing to that? Is that
Hockey?
is that because
It's a lot of sports, Canadians are very athletic, very sporty people. So I think it's just that everyone's falling on an outstretched hand in winter. So that's probably why. So I'm just surprised that it was non-displaced. I would think it's more for displaced ones, right? So, yeah.
Any other questions? No? Okay. Thank you all for joining us today. We will now take a summer break and we'll be back in September. And you can stay updated by following our social media accounts where we regularly share information about upcoming sessions. Thank you very much. See you.